Hello and welcome. My name is Alana Gordon. I'm a reporter and producer at The World, covering global health. This is a Facebook Live Q&A called The Coronavirus Pandemic, Surging Cases and a Growing Crisis. And with me is Dr. William Hanage, Associate Professor of Epidemiology at Harvard's T.H. Chan School of Public Health. Bill, thanks for joining us.
It's my pleasure.
And you can post your questions for Bill and me on Facebook at Forum HSPH and at PRI The World, or you can email them to theforum@hsph.harvard.edu. This Q&A is jointly presented by The World at PRX and WGBH and the Forum at Harvard's T.H. Chan School of Public Health. We are doing this on Zoom through Facebook, so thank you for your patience. To begin, Bill, some states seem to be making progress against the COVID-19 pandemic. At the same time, the country as a whole is setting new records in cases. Day after day, some states are reevaluating plans for reopening and have even begun reinstating restrictions that have been lifted. So to begin, where do you see us being at right now in this pandemic?
Well, I think I'd like to start by saying get used to seeing reports about record cases because, I mean, they're going to be carrying on going up for a bit. Where we are at the moment is that we have experienced an initial surge of infection in the northeast of the country, which has been pretty much brought under control, although obviously watch this space. And then there's been followed by a much more widespread increase in infections across the south. And those have been ticking up and ticking up. And as you know, they are now starting to roll into hospitals and so on and so forth. So we're effectively seeing the pandemic playing out at different paces and it's at different stages in different places in different parts of the country. And in total, the number of cases are rising and will continue to rise, I would expect, for some time to
come. You've written before that it's felt like deja vu in some sense, like March all over again. And I wonder if you feel like when you're seeing these surges, like we're back to where we've started, or if there's some way to prepare to prevent what we've seen before early on, for example, in the Northeast.
Absolutely. I mean, when I say it was deja vu all over again, I'm thinking about my experience and the experience of other people in my position in March, because we could see what was coming. And we were trying to persuade people to take it seriously and be prepared to take action. And that is not exactly the same as what's happened now because people are more aware of it. And as I think we may get to later, I have a suspicion that the outbreaks in the Sun Belt have been caught at slightly earlier stages, which may be a cause for some mild optimism. But the basic arithmetic of the pandemic remains pretty much the same. This is going to infect a very large number of people and it's going to sicken some of them much more severely than others. And unfortunately, a relatively large number are expected to die.
Why have compared to, you mentioned that maybe places are catching the outbreaks earlier, but when you say you are unfortunately suspecting or predicting that more people will die, we actually haven't seen as high rates of deaths right now in these newer surges, and I'm wondering how you can explain that.
Well, the explanations for the smaller numbers of deaths are that deaths are what we call a lagging indicator. They tend to follow the infections. And in fact, I would say to everybody watching this, every time you hear anybody saying anything about the pandemic or saying that one place has done well or another place has done badly, you should always add the two little words, so far, because this is going to take quite some time before it's done with us. Now, deaths tend to follow about 3-4 weeks after the initial infection. And so at the moment, we have been seeing a large number of infections in the South among comparatively well young people, and they've not been terribly severe. However, it's very, very difficult to have a large force of infection, as we call it, among one age group without it getting into another. And as it leaks from that age group into the older population, we expect to see more cases within people who are at risk. And unfortunately, they are much, much more likely to have severe disease and die. So there is reason to be cautiously optimistic that we might have caught it at an earlier stage, but it's not going to get us out of jail free.
So, and yeah, just in thinking about also the high rates of deaths in older populations, like in nursing homes, it's really striking how different that is, or how big of a portion comprises that.
Absolutely. I mean, but the interesting thing to note is that roughly speaking, at the time, we're doing this, thinking of Massachusetts in particular, which is, where I am, it's been we have roughly 60% of the deaths that have occurred so far have been in nursing homes. And that's also roughly true in Norway. However, when you look at the total numbers for each, that's about 4,800 deaths in Massachusetts and about 150 in Norway, because so far Norway has managed to achieve very limited community transmission. So this is one of the key things. If you can manage one of the best ways to protect the most vulnerable individuals is to not have uncontrolled high rates of community transmission.
So then when you think about a place like Massachusetts now seems to be on the downside of a curve, on the downslope. And then you also have places like Florida and Arizona that are seeing surges. It's such a different experience right now. So how do leaders and how do states calibrate their responses? Because obviously people don't stay in one place either.
No, absolutely. I mean, well, there's a question here that we can get to in terms of travel, but just in terms of to take your question from the way you put it, we have to remember that we do not have a pandemic in the same stage as we were saying in all parts of the country. So here, rates of community transmission right now are pretty low, I'd say. In places like Florida, they are pretty high. They have been pretty high for some time. They are hopefully slowing down, but we don't know that the sort of restrictions which have been put in place in Florida are going to be sufficient to actually cause the pandemic to start decreasing and actually to be shrinking there. Now, I might hope that could be the case, but I don't know that that's going to be the case. So you do need to be very responsive to local conditions. And that's one of the things which I think is extraordinarily important for leaders going forward, is to be looking very carefully at what is going on in the community where you are and being prepared to take decisive action to slow spread early on, because the last thing you want is what happened in the Northeast in the spring, which is you create a sort of tinderbox of transmission, which is concentrated among people who probably don't even really notice that they're infected and certainly don't have severe disease. And then that starts leaking into the vulnerable populations, starts infecting them, and you end up with a very large number of deaths.
How and we're going to get to a bunch of questions, but when you're looking at then rates of transmission, and when you're trying as a researcher and as a scientist that studies this, how do you assess when you see something changing in a community? What goes into, for example, do you have the information? Is it the testing rates? Is it like, how do you actually identify then where a community is at, and how do people identify that?
It's tremendously difficult. But one point of comparison which may be useful to give is Germany. So I was actually talking with a German colleague earlier this morning, and we were discussing Germany's response, which is, you may well know, has been very, very different to the United States. Germany is a federal country, but it had a very large amount of testing. As my colleague was saying, Germans get very nervous, they want to have a lot of testing, and so they looked at Italy and they immediately said, oh my goodness, we need a lot of testing. And they were testing the community, so they were able to detect that kind of transmission that was happening, and they started taking action very early on. And as a result, they've had a very good pandemic so far, that being the crucial sort of element. So if you want to look at testing, you would like to look at testing in the community. You'd want to have testing of relatively well people. Remember, deaths and severe disease are a lagging indicator. So by the time you find somebody who has died of it, there's very likely a large amount of transmission already happening in your community. And different states across the country have very, very different reporting sort of mechanisms. Some of them do not even report hospitalizations, which makes it very difficult to understand exactly what's going on there. And it would be great if there was a single reporting format. It would make it a lot easier for people like me. But unfortunately, there isn't. And there's no substitute really for digging into the data and looking at the local conditions.
I mean, we're having a very calm conversation right now, but that sounds incredibly frustrating to actually know the answers that you're talking about to be able to assess what's going on.
Yeah, it is. I mean, earlier in the pandemic, I spent a good hour every morning digging through whatever I was seeing on COVID Tracker and trying to figure out exactly what I thought was going on. And then I started to think, hang on, I can't distinguish this between something which is an artifact in the data because I've changed my testing reports. The same thing happened incidentally back in January when we were looking at data out of Wuhan. And it's a tremendously frustrating process, but it does come with the territory. Now, there's one thing which I would like to mention at this point, and there was an article in the Times recently with my colleague Maurizio Santiana, some work that he's been doing looking for what you can think of as combined predictors of spread coming in the next few weeks. These are like mobility data, the sorts of things that people are searching for, and importantly, the sorts of things doctors are searching for, which tells you something about the patients they're seeing. And it looks as if that approach may be able to predict increases by a couple of weeks. So that's one innovative approach. Another one, which I'm also very slightly involved with, is looking in wastewater for the virus, because we do shed virus in stool. It ends up in sewage. So by monitoring sewage, you can start detecting the presence of the virus in your community earlier than the point at which cases start becoming noticed by doctors. And so these kind of early warning systems may be very helpful to us going forward.
You referenced Germany and the Netherlands, and I'm just wondering, before we move into some of the other great questions here, when you compare to the United States, there are other countries, for example, that are not in the situation that the United States is in terms of leading in cases and deaths, that seem to have gotten a better handle on overall the pandemic in their communities. And I'm wondering if there are things that you take from those approaches that can be lessons for the United States.
Yes, I think there are many lessons. I think the first lesson is that, we shouldn't be fatalistic, because there's been a kind of shift in some quarters from being outright denialist to being fatalistic about it, and there's really no need to be. If you look at what Germany has managed to achieve, they've been having live soccer matches, or if you look indeed at Japan, and Japan is a particularly interesting example, because Japan has not had huge amounts of testing, but it did have very early introductions in relatively large numbers from Wuhan. It was one of the very first sort of exported cases from China. Was a tour group that ended up infecting their bus driver. And the bus driver was in the community for, I think, 10 days before he was eventually diagnosed. So there was enormous opportunities for transmission there, and there are many others as well, many other introductions. And yet, the exponential curve in Japan has been much more shallow. Now, there have been occasional interventions in states of emergency declared, and there have been some limited restrictions that have been necessary to avoid a damaging surge. However, it has been so far a very, very different situation. I'll be honest, I don't know why that is. I can make some speculation, which is informed speculation, but it is still speculation. Obviously, Japan has a reputation for being very hygienic. There's also a lot of masks that get worn there. And that is a major part of the discussion in the United States too. And if you've ever been to Japan, I don't know if you've noticed that people tend to hand out, there are people on the street handing out paper handkerchiefs near subway stops and stuff like that. And it's very rude to blow your nose in public. So I don't know if any of these things in particular are relevant to what happened there. However, taking them all together, it's reasonable to think that some of them could be helpful.
I was reading that Japan also has a pretty robust community health system where patients have direct relationships with healthcare providers that also take on a sort of contact tracing role. And it was interesting for me to think about kind of how healthcare systems and infrastructure may impact the overall kind of communicating and messaging and understanding and then responsiveness to something like the pandemic.
Yeah, that's really interesting. I'll be honest, I had not thought of that, but I think it's very true that you need to have a sort of continuity of care, and the ability of healthcare to work within communities is really important. It's absolutely crucial to contact tracing, because if you look at New York City has been actually working really hard on their testing, tracing, and isolation approach. And so far, they've been having a hard road. I mean, of the numbers of people they contacted, they weren't able to get through to a very large proportion of contacts. And that shows just how difficult it is.
So I want to get to some of these questions here too, which are really all over the place in terms of, I want to transition to something very different, but it's something that's been on a lot of people's minds. It has to do with the virus itself.
Mhm.
This question from online is, I've read that the virus has mutated. What does that imply?
That's an excellent question. And I actually wrote a thing with a couple of colleagues last week about it. So the viruses mutate all the time. This is not particularly, this is nothing to write home about. Mutations are just mistakes which are made when the virus is replicating its genetic material. And it doesn't have actually a very, very large number of mutations, or what we call polymorphisms. It hasn't accumulated a lot so far. However, there's one that's attracted a large amount of attention, which is, the technical term is D614G, which means that it's changed the makeup of one of the proteins, the protein which allows it to enter cells. And it's been suggested that this has made it more transmissible. Now, it's not actually clear that that is the case at all, because if you look at the D form of this, that's a form that was predominantly in China, whereas the G form is the one that got into Europe. Now, in China, I'm sure you'll remember well, China stamped on the pandemic pretty darn hard. So the G form has been declining, probably because China stamped on the pandemic, whereas the D form is the one that got into Europe and specifically into Italy, which spent a long time before it realized that it had a large outbreak on its hands. And once there was a very large outbreak there, that was what continued to infect Europe. And because links between Europe and New York City are much, much more numerous and common, that's what was the majority introduction into New York City. And that leads to, again, the dominance of the G form across the world, around the world. Now, it's possible that it was by chance. It's also possible, although I actually would underplay this myself, that it could have some effect upon transmission. The reasons to be, the reasons to think that are that you can manage to make virions with that kind of particular mutation. They seem more likely to infect human cells in experiments. But infecting human cells in experiments is very different from actually infecting a human, being shed by a human, getting into a droplet, and then transmitting to another human. So it could be relevant, but it's not necessarily. We've seen similar results in Ebola, which didn't play out into a difference. And the other possibility is that if you look at patients who have the mutant form, they seem to have somewhat higher viral loads. But those are very difficult to interpret because it depends at what time in the infection they've caught. We don't know what transmission, what the viral load is at transmission. By definition, we do not measure the viral loads of patients at the time they transmit. And a lot of that may be asymptomatic. And so I think that it has mutated. I also think that the mutation doesn't make a huge amount of difference to the way we think about the pandemic.
This question, there's a lot of questions coming in about schools reopening. And I think it also relates to when you think about different populations and exposure. And so you've talked about why reopening schools should be a top priority.
Right.
Why do you think state leaders are acting with urgency right now? Or are they acting with enough urgency?
I think that schools are obviously really important. And you're referring to an article. I wrote an article with my wife, who's also an infectious disease epidemiologist, in the Post last week. The way that people think about schools, in my opinion, and indeed the way people think about the economy as a whole during the pandemic, is somewhat wrong. As I've said earlier, what we want to achieve is low rates of community transmission in order to prevent losing control of the pandemic and damaging surges into healthcare. I will just put a parenthesis here and say, when I say damaging surges into healthcare, I don't just mean the sort of things we saw in New York City. I mean anything that prevents healthcare being able to do its usual function, because healthcare has a lot of functions like, vaccinations, like regular checkups and things like that. If it becomes dangerous to go to those, then that's your healthcare system compromised. But back to schools. If we want to limit community transmission, we've got to decide what we're going to contribute to community transmission and how we're going to prevent it getting too high. So the way that you can think of it is like you have a budget. You've got a certain amount of transmission that you are happy to allow. And if it adds up to being too much, then you're going to start getting a growing outbreak, or it's going to end up becoming potentially overwhelming. You can decide how much you want to allow. It might be none at all. You might want to be New Zealand, or you might want to be South Korea, or you might want to keep it sort of going along at a point where it just infects people slowly and steadily and you don't get a very large surge. Once you've decided that, you've got to decide what's most important. Now, schools are one of the most important parts of our society. Not only do they educate kids, they feed lots of them. Some children are safer in school than they are at home. And closing schools particularly hits the vulnerable. It's also very true that for working parents, and we are in that category, school closures makes it very much more difficult to be doing your job. And because you have to be working from home potentially, and you also have to be homeschooling. That's what I spent the first few hours this morning doing. So there's every reason to think that schools should be a priority. But once you open them, you run the risk of that contributing to community transmission. And that aside, if you have a point when community transmission is so high that you're going to have to be going back in the direction of more severe restrictions, then schools may close anyway. So I think what we need to do is not open until we're really at the limit of another outbreak, and then in a few months add schools again on top of that. I think we should be building schools into our plan. And that means prioritizing different parts of our society and the economy. And it's really difficult to make those decisions. I accept that, and I don't want to say that I have all the answers. I really don't. However, I do think that's a much more useful way to think about it.
Do we know how well kids catch and transmit COVID-19?
I have a kid trying to come in here to join me. That's lovely, darling. You can take it away. I'm talking now. It had to happen sooner or later.
That was on point, on cue.
Yeah. Do you know how much? Yeah. So there's a reasonably large body of data coming out from this, and I think you have to remember all children are not alike. So younger kids seem to be less likely to become infected and less likely to transmit. Now, I'm saying seem to be because the studies are really hard to do. I mean, just think about it. If you're studying a household and you sort of are looking to find people who are infected, you're going to look for people with symptoms. Adults are more likely to have symptoms, so they're more likely to get tested. And so you think that they are the index case, and you then sort of test the people around them, and you find the kids, and you say, oh, the adult must have transmitted to the kid, when it could have been the other way around. There have also been far fewer opportunities for kids to acquire infection due to the interventions of the last few months. However, I do think it's plausible, given the fact that some of the biology of this involving the receptor that the virus attaches to, that kids are less likely to be infected. But you then have to take on top of that the fact that kids in schools make very different types of contacts than adults in workplaces. And it's very difficult to prevent them they may make twice as many contacts, so it could be the case that even though they're less infectious per contact or less likely to be infected per contact, they still manage to contribute a fair amount to transmission. And it also looks less clear that they are unable to transmit. So the data are...
It looks less clear that they are unable to transmit, meaning...
Yes, so it looks a little bit less. I'm thinking of a few studies I've seen. There was one in Israel recently, which has been... Israel's reopening was derailed, at least in part, by a large number of outbreaks associated with schools. A study from there did suggest that the younger children were maybe 80% as likely to transmit. It wasn't statistically significant. I do think it's plausibly lower, but again, the crucial question for an epidemiologist is how much does it contribute to transmission overall? And that's that's very tough. Now, older kids are a different story. When I say adolescents, I mean these high schoolers and stuff. High schoolers they seem to transmit much more like adults do, basically indistinguishable. And also they and younger adults are much less likely to practice anything resembling social distancing. I mean, I dread to think what I would have been like if I'd been a teenager during the pandemic. So those groups are quite important, and I think we need to be thinking about that very much going forward. I'm not sure. Schools are really, really important. I'd be prepared to forego quite a lot of things personally in order to be able to keep the schools open. But those decisions are tough, and they're going to have to be made going forward.
Not easy. This question is from Marissa. We're seeing more reports of long-term side effects of COVID-19 infections, even in young people, for our theme. But do we have any data on the prevalence of long-term effects? Is it possible the US will have more patients with long-term disabilities because of COVID-19 infection? I mean, I'm so curious about this too.
It's a great question. It's a really good question, and one which is actually very much on my mind, because I discovered last week that indeed an old friend of mine is one of those people. She's originally from the Netherlands, but she now lives in Edinburgh, and she's an infectious disease doctor who worked, in fact, briefly at the Chan School some time ago. And she became infected and suffered disease for a very long period of time. She ended up writing an article in a newspaper about it to call attention to this. It's unclear what proportion of people who are infected get that. And this is for the same reason that we don't see the mild cases. I should come back. Do ask me in the future about how many mild cases there are, by the way. This is important. We don't see mild cases, but of those who have symptoms, it seems as many as 10% may have a relatively long course of disease. Whether that's going to feed into chronic stuff going down the line, I don't know. I mean, it may do. There's been some suggestion that people who are infected with COVID could be more at risk of developing type 1 diabetes. However, I would caution that, people who are on the verge of developing type 1 diabetes might be pushed over the edge by the infection, because, it makes sugar control more difficult if you have, severe fever and things like that, lots of stress hormones. So this is again a moving target, but I think that it's something that needs to be taken seriously, especially if you're listening to those people who are saying stuff like, oh, death rates are very low, or, oh, it's just the flu. It's really not the flu. The number of people who have died in the city I live in alone, in Cambridge, are around what you would expect if every single man, woman, and child in the city had been infected with influenza. And, obviously, not everybody in Cambridge has been infected with SARS-CoV-2. So that tells you, just that alone gives you some indication that it is a more dangerous virus than influenza, even if many people do not have severe symptoms.
This question's from Greg. It's about traveling in terms of comparing, we talked about early on in the discussion about different stages or different points in a surge. With cases surging across the US and misinformation the general public's may be exposed to daily, do you think travel restrictions between states will become a new normal? And what effect might that have?
So travel restrictions are really only sensible between places which have very differing amounts of disease. And they're only really useful at the start of an outbreak and the end of an outbreak. So I'm not surprised to see the Northeast, for instance, being anxious about travelers coming from other parts of the country where disease is more prevalent. However, if it gets to a point where you're as likely to be infected somewhere else as you are, going to your local corner store, your local convenience store, then there really doesn't make much difference. I mean, if it's a sort of, there's a point at that stage where restricting travel really doesn't do very much for the state of the pandemic. I mean, it's what you want to avoid doing, if possible, and in particular with a virus like this, in which introductions seem to matter, you want to stop introducing it to places where it hasn't been present much recently, because as you probably are aware, this virus appears to have what the technical term for this is an over-dispersed reproductive number, which is, what that means is that a minority of people do the majority of infecting. So a consequence of this is that most introductions to a community will go extinct, but those that don't make it really big.
Hmm.
And that is one of the reasons why we have seen sort of when you have an introduction to a community which manages to infect very large numbers of people, hundreds, South Korea saw one of those, then you can very rapidly get a lot of transmission chains started, even in a small town. And small towns, I would point out, may be those that have less ICU capacity.
This question relates to that, sort of, from Priscilla. What's your impression of the push by many scientists that the WHO consider airborne transmission as an important factor of infection? It's on a lot of people's minds.
Hi, yeah, good question. I've already weighed in on this, so I'm going to try and offer some nuance to this. So, what airborne transmission indicates is the capacity, or it suggests the capacity of the virus to spread in an aerosol. So you've heard about droplet transmission, and well, aerosol transmission is like droplets, but they're smaller droplets. Now, those smaller droplets can drift further, and so the whole thing about, the 6 feet distance to prevent being infected might, not be enough. However, the letter which was sent to WHO is, it makes the case that aerosol transmission can happen. Now, that's not the same as saying that it does happen a lot. I mean, the way to think about this, or, the way I'd think about it is that, if your football team manages to win a game, great, but it's got to keep winning the games in order to, make it in the league. That's the situation. In the same way, the fact that the virus can transmit by this route does not necessarily take into account whether it's contributing a great deal to the dynamics of it, by which I mean, if it's responsible for 10% of infections and the interventions we're doing can get rid of 90% of them, well, 90% would be enough to bring it under control. And at the moment, we don't really have any good idea for how much transmission is potentially by that aerosol route. You have to remember also, a droplet is larger than an aerosol particle. And because it's larger, it can contain more virus. It's just bigger. There's more room for it in there. And so the infectious dose from a droplet is likely to be higher than from an aerosol. And as a result of that and a bunch of other things, I think that the jury on the proportion of aerosol transmission that actually occurs is well out. But it is a very difficult question to answer. So there have been studies which have been done. I've seen some from the University of Nebraska Medical Center and another one from hospitals in Wuhan that have detected virus genetic material in aerosol particles. But that's not necessarily the same as the virus being viable or that being enough to infect a human. But I'll be honest, we don't know what the infectious dose is. And we also don't know how much virus is being sort of replicated in the throats of people who are just beginning to become symptomatic. So there's a lot of unknowns there. I think that they are right to point out that, absence of evidence is not evidence of absence. That the fact that you have not been able to nail down aerosol transmission doesn't mean it's impossible. However, in my view, the authors of that letter are, going a little bit too far in saying that this is a huge, clear and present danger. And I think that the public ought to, take it in that light.
That's a helpful perspective. This question's from online, and we're going to be wrapping up soon, but are we in a second wave now? What does it mean to be in a second wave at all?
So again, that's a lot of people are asking this question, and thanks a lot for it. Now, I mean, my personal feeling is that when we speak about waves, that's a misleading metaphor, because a wave, in the ocean, doesn't go away. If you're at the beach and you're standing in the sea and the wave comes over you, it doesn't go down again because you're saying, no sea, get down, get down. It's got nothing to do with you. So the reductions in transmission that we have seen are not actually because of the virus or because of anything that's changed. It's because of stuff that we have done and because of human actions. So the terminology of waves comes from the 1918-19 flu pandemic. That was an influenza pandemic. It killed about 50 million people worldwide. And there was a first wave in the spring, followed by very little disease in the summer, and then a huge second wave in the fall. And that's kind of exerted a sort of post-traumatic stress on epidemiologists who are always worrying about first waves and second waves. What I prefer to think of is in terms of surges. And the reason I prefer surge is because of the fact that it reflects it can happen at any time and in any particular type of weather, as we're seeing across the South right now. And also because of the fact that surge echoes the terminology that we use when we're thinking about overburdening ICUs and healthcare and stuff like that. So right now, if you insist on talking in waves, which a lot of people do, and believe me, I've done it myself, so I'm not trying to, I have gone down that route. It's a very easy metaphor to reach for. If you're thinking of waves, the Northeast has seen one. We're now seeing one of the first one, sort of herald wave, you might call it, across the South, and other parts of the country have yet to get it. And moving forward, as we give the virus more opportunities to transmit, then we expect to see increased transmission elsewhere. And yes, I believe that we will see future surges. And remember, right now, it's kind of easy to keep your distance outside, but we've got a long fall and a long winter ahead of us. And this is going to be, this is a marathon, not a sprint.
And it sounds like we're still early.
We are very early, yes. So if you are going to be sort of reasonably optimistic about the proportion of people that would need to be infected before their immunity started to force the virus to slow down, that's about 50% of the population, maybe more. Now, if that happened in an uncontrolled fashion, then that would occur at the peak of the wave, right at the top of the epidemic curve, and then you'd have all the other side of it to go down, and all those people would be being infected unnecessarily. So those are obviously, I think, things that we would like to avoid. It is true that the majority of cases of COVID-19 are mild, but the majority of cases of COVID-19 can still transmit and get into other people who may not be so fortunate. Remember that even though a small fraction might suffer very severe disease and a small fraction might suffer deaths, a small fraction of a very large number is a large number. And I think we have to bear that in mind going forward.
I just want to squeeze in one more question. And typically, I kind of like we wrap these up with kind of the big picture, which it seems like you've just gotten to. So I actually want to get a little more specific because as people are thinking about surges or going back to work, one question that's come up a bit is about testing and antibody testing. How do you see these results being used when making decisions about getting to work, school, shopping, socializing, and is that a good tool to be used? And also, are they accurate and helpful?
So that's a great question. So the antibody tests, as I'm sure you all know, are things that can tell you whether or not you had the infection in the past. Now, there's a whole range of these. We're now getting some which are quite good. There was a sort of frenzy a few months ago in which people were using some which were not so good and which had a relatively high false positive rate, meaning that they told you you'd been infected when you hadn't. However, we're getting reasonably good data now. It looks like 20+%, maybe as much as 30% of the population has been exposed in some places that were very, very hard hit in the spring. Note, by the way, we'd have to go through that again to get to the levels of population immunity I was talking about earlier. It's also not clear that everybody who's been exposed and developed these antibodies is actually immune. We don't know enough to say whether that's the case. People vary in their antibody titers, which means the numbers of antibodies that there are there. And there appear to be some people who are capable of mounting a response from a different part of the immune system called the T cell response. But that's not captured by antibodies. Now, immunology is a horrifically complicated subject, and I don't want to pretend to know more about it than I do. I'm only an epidemiologist. However, I think it's worth bearing in mind that we're not going to really know what prior infection does in protecting against subsequent infection until a reasonably large number of people who were infected in the past become exposed. And that is probably going to happen whether we like it or not, but it's not something that we should be inviting.
Finally, I asked this to your colleague Caroline Bucky last week, just to wrap up, which is, what advice do you have, or how do you manage figuring out as places like Boston reopen more, whether an activity, going to dinner, or having a backyard get together or whatnot is a safe choice?
It's a super good question, and it's also
How do you personally navigate this?
so. Um, the personal thing right now is that I look at the rates of community transmission and I note that they are low. So they're actually, although the highest rate of community transmission in Cambridge is, just a few streets that way right now. I think about the rates of community transmission and I think about how likely we are to be exposed. And I then, make a judgment based upon that. I have only been indoors in another place a few times since the pandemic started. I think I've been to maybe 3 or 4 stores. On the other hand, been strawberry picking loads of times. Strawberry picking is outdoors. It's easy to maintain distancing. You can wear your mask and everything. It's great. And then you get strawberries into the bargain as well. Now, going forward, I would sort of start considering rates of community transmission and being more restrictive. I would certainly not go into a crowded indoor space. There should not be any crowded indoor spaces anywhere right now, because those are places which run the risk of super spreading. And that's something we should all wish to avoid. And since the spring, I've been doing we've been enacting infection control, basically considering that the house is a green zone, anywhere outside is like amber, and then some places where the virus is would be red. And that means, we wash our hands for 20 seconds every time we come into the house. We've stopped changing our clothes recently because we think that community transmission is probably pretty low. Obviously, we're wearing masks and stuff like that. And I don't know if you've noticed, when I get an itch on my face, I try to scratch it with my glasses.
I have noticed.
Try and avoid touching my face. So these are all sort of steps which, behavioral change is hard. So get into it early. But I note these are ways that we are protecting ourselves. And the thing about public health is it's not an individual thing, it's for the public. And what we want to help is we want to take action which can stop other people becoming infected and stop that community transmission, which I've been talking about throughout. Because, chances are, if we became infected, we might be okay, but that's not the point. I don't want to become infected because I don't want to transmit it to somebody else who's less fortunate.
Well, I think that's a good point to wrap up. We've run over a little bit, so thank you for taking all these questions. And that concludes our Facebook discussion. Again, thank you, Phil. You can view this discussion on our Facebook pages and send feedback at Forum HSPH and at PRI The World. And this Q&A has been jointly presented by the Forum at Harvard's T.H. Chan School of Public Health and the World from PRX and WGBH, excuse me. Thank you for viewing and listening, and let's keep the conversation going.